Hello, everyone. Good morning, good evening, good afternoon from wherever you are joining us in the world today. And welcome to another episode of the Realist Lens for researchers who keep it real. Today, we're weaving together some powerful threads, bringing theory to practice, method to meaning, and story to structure. Our guest works at the intersection of clinical care, cultural safety, social prescribing, and realist research. From working alongside Aboriginal communities in remote settings to drawing on narrative medicine and personal experiences, their journey shows us how realist approaches can be both rigorous and deeply human. So, wherever you're listening from today, get ready to dive into a rich, reflective conversation on making research real, responsive, and relational. And I'm really excited to welcome Katherine Zippel. Katherine, hello. How are you? Good afternoon from Australia.
Thank you. I'm great. Thanks for inviting me.
No worries at all. I'm so happy that you're here. And first of all, would you be able to share a little bit about the trip that you're doing at the moment? Because I know that you've been traveling around the Northern Territory so much over the last couple of days, and it's all very exciting.
Yeah, I've recently just gotten back from a place called Kintor. It's on the Western Australia border with the Northern Territory. And I've traveled about 7, 8 hours through to Alice Springs on unsealed roads just for the weekend. And then I head out to another Central Australian community. I'm a general practitioner. I have been a GP for geez, maybe 7 years now. I did my training in remote parts of the Northern Territory, so on the Tiwi Islands, on Bathurst Island, and then I also worked for quite a while for Congress and Aboriginal Controlled Health Service out in Mutijulu, which is the Aboriginal community that's at Uluru Ayers Rock. As you had mentioned, I'm also doing a DPhil PhD, but part time because I still work clinically. And I'm a student at the University of Oxford, and I'm studying evidence-based healthcare. My research focuses on cancer care in general practice and how social prescribing can support people navigating life after treatment. It's a topic that I'm deeply passionate about because I'm in my fifth year of breast cancer survivorship. I come to realist research not as a methodology expert, but as someone who's found in it a way to make sense of real world complexity that I see in every day, especially when working with First Nations communities. I myself am Native American Cherokee tribe, and realist approaches have helped me explore how care works or doesn't across different cultural and structural contexts.
Catherine, thank you so much. Not only for the trip that you're doing at the moment, but also giving a little bit of an introduction, which again shows so many threads coming together and so many different angles from your clinical practice, your research practice, your cultural background, and also your personal background. And I think that all weaves together so nicely into the conversation that we're going to have today. Because with so many threads and all that complexity that you bring to your work and into the approaches that you bring. I guess that is one of the first things that made realist work click for you, how we could explain this complexity. Did you find that both in your practice and in your research? And is that how you first encountered realist evaluation and synthesis?
Yeah, so I first encountered realist evaluation during my early work at a university. I was a United States Peace Corps volunteer in Ghana, West Africa. That would have been 2009. At that time, we were rolling out universal HIV/AIDS testing and screening programs based off of Paul Farmer's work in Haiti. We were doing this across 10 clinics in a health district. And this was after significant stakeholder engagement and qualitative research to guide program implementation. However, unfortunately, found extremely low uptake in some communities, but not in others. I was grappling with why certain protocols seemed to work in one setting, but not another, even when the context appeared similar on the surface. So when we went back to the original research that we'd done to guide program implementation, we couldn't find a logical answer for the variability and outcomes that we were seeing across different communities. It was then that I went back to review the research literature. And in a moment of desperation, I was lucky enough to come across a study using realist evaluation. And I found it was an aha moment for me. And I found that realist methodology offered a language and a logic for unpacking the complexity I was seeing in practice because it moved beyond asking, does this work, to, well, what works for whom, in what circumstances, and why. And at that stage, we paused our rollout and began a preliminary evaluation of the program using realist methods. I've also seen how realist thinking can be critical to program implementation in my work as a remote general practitioner in Aboriginal communities, where health interventions are deeply entwined with social, cultural, and historical factors. Realistic research for me has given me a way to honor that complexity while still working towards actionable insight. It's helped bridge the gap between evidence and lived experience, which also is what draws me to narrative medicine. Yeah.
Thanks, Catherine.
Sure.
No, that's fantastic. It's done so much for you, and I think for many people as well, because I think it's quite a a common way that people necessarily go in first into realist evaluation or realist synthesis, which is an initial frustration into what they may see in practice or in research or what's available to them to understand the world. And then all of a sudden they find this approach, and that again is not a panacea, of course, but it does give you some really good answers to some difficult questions, embracing complexity, not necessarily simplifying complexity, which
Mm.
again, that's one of the things that you mentioned in your work with all these different threads that I think also is quite compelling. This embracing of complexity rather than simplifying it, so to speak.
Yeah, definitely. Another striking example I can think of where we've used realist evaluation to embrace complexity was during the early stages of the COVID-19 vaccine rollout that we were doing in Mutijulu, the Aboriginal community near Uluru. And at that time, initially, there was a national urgency to vaccinate remote communities, due to their heightened vulnerability. But the top-down approach just didn't resonate locally. Again, another situation where uptake was low, of vaccines in this case, and there was visible community hesitation and at times resistance. So, for us, using a realistic lens at that time helped us understand that it wasn't simply a matter of access and education. The intervention, which was a fly in vaccination team with limited local engagement, it just operated on assumptions that simply didn't hold true for that context. It presumed trust in the health system and a belief in biomedical messaging and that they would accept a rapid response strategy. And this is for a context, a community with historical trauma that was linked to medical mistreatment and land dispossession. These assumptions that really needed to take place for the intervention, vaccination to happen just didn't hold true. Realist evaluation in that setting really helped illuminate why the interventions had faltered. We looked at mechanisms of trust and cultural legitimacy, and relational continuity were key and they needed to be activated. So, what shifted things for our vaccine rollout was re engaging through local Aboriginal health practitioners and respected community leaders who led culturally grounded conversations in language in spaces where people felt safe. These were things like family gatherings in the home where whole families were present and could make a collective decision together about being vaccinated really helped improve our rollout. And when we had reframed the approach to support local control, we respected cultural protocols, our uptake improved. The context hadn't changed, but our understanding of what worked for whom and why had deepened, which is why I think it worked. And that is the strength of realist evaluation. It centers on that dynamic relationship between context and mechanism, and helps surface solutions that are invisible in more linear models of evaluation, which is why I found
Absolutely.
it to be a very powerful tool.
Absolutely, Catherine. That is brilliant, and it gives such a clear example of how it's helped you understand what works or not in delivering culturally safe, community-led care, particularly in instances where, as you say, more linear models that maybe focus on the surface or on the experiences, or that at that level may not provide the answers, or you may start looking into the different lenses, different variables that are going on, but not necessarily giving you the why or the answers into what is happening. So that is certainly an interesting and very useful example. In that example and in other examples within your work, I've also seen your use of narrative medicine being quite central to how you do your work and some of the studies that you do. How does that kind of storytelling complement or contrast with realist approaches? Have you been using them working hand in hand? Have you used them separately? I'd love to hear your thoughts on that.
Yeah, I absolutely see narrative medicine and realist methodology as deeply complementary. At first glance, they may seem different. One is grounded in story, subjectivity, and emotion, and the other in theory driven analysis and explanatory logic. But both are fundamentally about meaning making, understanding how people experience the world and what influences outcomes in complex systems. In realist work, we look for mechanisms, the underlying drivers that explain why something works or doesn't in a given context. In narrative medicine, on the other hand, it helps surface those mechanisms by inviting people to tell their stories in their own words. A patient's story might reveal, for example, that what motivated them to attend a walking group wasn't improving cardiovascular health, but feeling seen again after treatment. That kind of insight helps realist researchers go beyond surface level interventions and uncover deeper layers of causality. So, in practice, narrative medicine gives me the texture and the voice that help interpret realist data more meaningfully. And it ensures that when we talk about context or mechanism, we don't lose sight of those human beings that those words stand for. I see realist methodology as something that gives structure to those stories, and narrative medicine ensures that those stories are honored. So yes, I see them working hand in hand. Both approaches challenge reductionism. They embrace complexity and invite a more relational, humane way of thinking about evidence and care.
That's so great, Catherine. Thank you so much. And also related to that, again, being method neutral, realist evaluation, realist synthesis, you can really intertwine those different areas and those different approaches of data collection and understanding those stories. And I guess, as you're saying, being in your work patient centered, but also in your research, participant centered, to ensure that those voices and those stories are not only from our perspective, but also in that teacher learner cycle, right? That we're constantly adapting and evolving and refining those theories based on those narratives and those sources of information from the key stakeholders that may be involved. So that's great. Thank you for sharing that. Because again, with all these interrelated concepts that you're involved in and all these different angles and threads from clinical to research to practice, the realist approach is sometimes seen as academic, complex, quite out of touch, that it only is going to be an academic exercise rather than something practical. But you have used them in real world, emotionally rich contexts, with different cultures in remote settings in community-based care. So what advice would you give to someone who may be new to realist evaluation, who wants to use it meaningfully in everyday practice, wants to translate all these fantastic ideas and mechanisms, program theory, and then translating that into the real world complexity of maybe community-based rural cultural care?
I suppose it's the advice that I give myself. I think it's a really important question because when you hear context mechanism, outcome configuration, that does sound very academic. For me, I've always thought of realist evaluation as structured curiosity about staying open to the ideas that things work differently for different people in different settings and for good reason. So I try to understand that. So, my advice to someone new is start with stories, listen carefully to how people describe their experiences, and ask yourself what made this work for them? What was on around them that made it possible? I think this is already realist thinking. You don't need a PhD in methodology to begin. I think you need humility, curiosity, and a willingness to ask why and for whom at every turn. And don't be afraid to start small. You don't need a formal evaluation project to apply realist ideas. You can use them in clinic, in program planning, even in conversations with colleagues. Try noticing what patterns emerge when something succeeds or fails and think about underlying drivers. Over time, you'll start to see mechanisms everywhere. Is what I found. And then finally, don't do it alone. I think realists work thrives in dialogue. So finding others to bounce ideas with, especially people with different perspectives, I think is really important. Some of my best learning has come from sitting with Aboriginal health workers, community members, and patients and asking, does this explanation make sense to you?
And that's fantastic. Thank you so much. And there's three things that I'd like to emphasize that you mentioned, and I was just making a couple of notes on that because they've made me think as well about the importance of critical thinking and asking the why and the how and going deeper. Because very much a yes or a no answer may not necessarily give you the depth or the nuance that is very common in the social complex world when we're dealing with human beings in all these different layers of reality. Because particularly when you're talking around medicine and healthcare, and it's an element that all these things intertwine, which makes it fascinating. So I completely agree that the realist approach is very cognitively stimulating because you're constantly asking why, how, what is it about this, what is it about that, which again, those mechanisms everywhere that you've mentioned, you're going from implicit to explicit. These
Mm.
mechanisms that, that we sometimes, I think we know what's going on here, but we're kind of showing our cards, if that makes sense, showing what's really going on underneath. And I think that's what makes it so interesting as well, the explicit nature of putting those mechanisms and the stakeholder involvement. I think is so critical, of course, of any projects. And I wonder if you'd be able to touch on that a little bit more, because you've mentioned around dealing with stakeholders for different cultures. Maybe there have been some language barriers in that as well. Maybe even some issues with power dynamics when it comes to going from a research project to community and rural communities that may not be necessarily exposed to research in the way that way we do it. Do you have any thoughts on that from your experience, how those stakeholder involvement has been in those communities?
Yeah, all of the projects that I've done in these remote communities, we have brought key members of the community into the project really early. They've been involved in the development of the project and informing a larger group, a research group of community members to help us decide how we're going to carry out the project. And so I think that having a diverse, an investigator team that includes locals, that's local dominant is key, where they're felt to be driving the research. Certainly, with my COVID-19 example, we had a federal and state mandate to vaccinate, but it was really, key community members who felt quite strongly about it that were and Aboriginal health practitioners that worked for the clinic that we were working with and saying, okay, this is your traditional land. This is your community. I know that you want to protect this community like I do. How do we make this happen? And letting, changing, I guess there's always going to be a power dynamic, but it's more egalitarian. And, coming with humility and coming and saying, I have these skills. What skills do you have? I'm just here as a tool for you to utilize to improve your community's health is important. And I think with the COVID-19 example, I had a little bit of fear because I deeply wanted those people vaccinated. But I knew at the end of the day, if the decision as a community was that they didn't want to be vaccinated or they didn't want us to look at researching how we implement it, then I needed to be in a position to respect that decision. And I did, I had that fear, well, what if people say no? And they didn't, but what was key to that project was that was very much community driven with where we supported it. And it also enabled the project to be a moment to upskill locals because the idea is eventually, if they want to carry out program evaluation, they can do it. They don't need an outsider coming in.
Certainly, Catherine, and I love that. And I guess that it also shows one of the strengths, which is the iterative nature of the project, that you go with some certain ideas at the start, but all of a sudden with the stakeholder consultation and the experiences, it may have to shift slightly to meet those needs and to build those program theories to understand the reality of what is going on for all these different stakeholders. So I find that really, really interesting example.
And I hadn't pointed out earlier that I came to realist methods very much using community participatory methods. And realist methods allowed for me to continue doing that, but was very much more theory driven. And so that it was a natural thing for me to sort of evolve to, because of that.
Yeah, certainly. And I guess it's as you say, it's it's a synergy that can be that if you synergize the strengths of both, then it can give you some really deep and rich information that then can help those stakeholders that you're trying to help, of course, in those communities. You've mentioned around your perspective around clinician, the work that you've been doing, researcher, as a survivor as well of cancer. So, how do you think realist synthesis and realist evaluation can help us within this complexity in healthcare? Because there is so many different layers in healthcare, from patients to providers to community-based care to private, public healthcare. There's so much that goes on, and especially those living in marginalized systems or communities. How can realist approaches help us in this healthcare environment?
For me, realist methods, synthesis evaluation gives us a way to make sense of the real lives people are living, especially those dealing with chronic illness or who are navigating a system that wasn't designed for them in mind. As a cancer survivor, I've certainly experienced what it's like when healthcare focuses on the treatment and misses the rest of your life, your fears, your relationships, your identity. It can feel like you're being flattened into a diagnosis, like the system only sees one part of you. And as a clinician, I see this happening all the time, especially with patients from marginalized backgrounds. When we treat everyone the same, often miss what actually matters. I think realist synthesis helps us resist that flattening because it encourages us to ask what works for whom, in what circumstances and why. It helps us explore the messy, layered realities of people's lives and design care that responds to those realities rather than ignoring them. I think that's critical. So instead of trying to squeeze everyone into one model of care, realist methods allows us to build a healthcare system that flexes, one that listens, adapts, and honors difference.
I love what you say that there around the design and around how the system is built, and therefore as it's built, how people experience that system. Because certainly a one size fits all approach, particularly for marginalized communities or more rural communities or Aboriginal communities or cultural differences, in particularly in the world of today being so globalized, then it certainly can asking those critical questions and being more open to the complexity and the answers of it depends rather than yes or no can sometimes feel quite liberating. And I know that maybe decision makers not necessarily like the answer of it depends, because that seems like, oh, well, where should we go next, right? But it certainly shows more nuance. And as you say, it shows how the world actually is like rather than what the world should be like. And I also find that quite fascinating. You've mentioned around all your examples. You've mentioned around, for example, narrative medicine. You've mentioned around the weaving of all the experiences that you bring. There'll be people listening to this that are also in similar positions, or indeed want to also go into realist approaches within a community-based settings using this community-based approaches. Do you have any three pieces of advice, three things that you'd like to say to those people from your position that you're in right now, from your experiences and doing your studies whilst working, for those that are interested in providing a culturally safe, community-led, realist approach, studies or research? What are the two, three things you would say?
Just go for it. Get a mentor. If you have no familiarity with realist methods, get a mentor. Join the realist newsletter. It's a fabulous and generous community, people who do this type of research. The next thing I would suggest is, gosh, I don't know. When I love to say that there's a lot of research that can be used to drive how to implement realist methods in First Nations communities or more marginalized communities. But as I searched, there is not very much. I found one study, which I can provide with you later, that looked at realist methods in First Nations groups, but there's not enough research. We need anyone who's passionate about doing research in this area to just start. We need to be forming a network. Reach out to me, start networking, whether it's through LinkedIn, whether it's through your organization. Um, and find other people that are passionate about this area because we need to be publishing more. We need to be talking about this more. It's a really, really powerful methodology to be used, particularly in the post-colonial world and areas where there's still a substantial amount of psychological colonialism. And it's such right now it's very iterative. People are learning by doing in this area. Be part of the conversation. And I feel as a novice, I've been very welcomed into the community. One of the things as I've been trying to look at, particularly how to implement this type of research and program evaluation in First Nations remote communities, is I've really wanted someone else who's out there that's already doing it that I can learn from. Is going to tell me how to do it. But the reality is, I have not found that person. And I've had to make a conscious decision that I need to be just doing the work. And if no one else is doing it, well, then I pave the way. And if I start putting myself out there, other people who are also doing it are going to pop up and we can band together. So I don't know that that's very constructive advice, but join the community.
Catherine, we'll go through things there. Number one, get a mentor. Number two, join the community, so the newsletters. And number three, reach out to Catherine. If you're listening about this and you want to build this community, which I think is so important, the work that you're doing, Catherine, and so meaningful, because one of the main things as well that I'm very passionate about is the accessibility of realist approaches, and not only focus, certain areas or certain countries or certain languages, but actually these ideas and this lens, this way of thinking can be so transformational for many people. So, as you say, building those communities of practice that can then develop into further research streams, into further um, and into further networks and collaborations, I think can be a fantastic next steps for this research and many others to come as well. Is there anything else you'd like to add, Catherine? I've really enjoyed hearing from you and the conversations that we've been having. Is there anything else you'd like to add for our conversation today?
I'm an early into my DPhil. I'm finishing out my first year soon. I do think that there's a vulnerability with putting yourself out there, with publishing, with talking about the research that you're doing, especially when you are early on. But I think that it's so important to do it. I learned so I started a blog and I blog about my experience. I use storytelling about experiences with patients or with myself. And I talk a bit about my research. And I plan to continue as I do my DPhil, talk about everything that happens, the good, the bad, because I think there's a power in that openness and that vulnerability that helps move research and move the field forward. And I think we should be embracing that. So it's very normal to feel a little bit apprehensive about being putting yourself out there and being vulnerable when you're early on in your DPhil, but pushing past that, I think, is just part of it. So embrace it.
Couldn't agree more, Catherine. And I think that's such a lovely, positive message to wrap up our conversation and embrace it. It's a journey. There'll be light bulb moments, there'll be hurdles, but it's all worth it to understand the complex world of the social world. Catherine, it's been an absolute pleasure to have you in the Realist Lens. Thank you so much for sharing your stories, your research, your views, your advice, and I'm really looking forward to talking to you again soon, I'm sure. And good luck with all the work you're doing right now in the Northern Territory. It's fantastic.
Thank you so much, and thanks for having me.
Thank you, Catherine. And thank you everyone as well for listening to the Realist Lens, and I'll see you next time. Thank you so much.